All right, and then I'm going to share my screen. I have slides. I know there right now there's only a few people here, but I'm really happy for people to jump in with questions at any point, and definitely can save time at the end for questions if others do join, or if it ends up being that this is not the best time, then people are also welcome to reach out to me separately at another time. Um, so I'll just briefly introduce myself and then we can just kind of get started. So I'm going to be talking today about prenatal exposure to substances, the impact on the developing child, and then also the interventions that we have that can help. And that will focus mostly on interventions for FASD or fetal alcohol spectrum disorders, because that's the area of intervention that we really have the most research support to in terms of efficacy of interventions. Um, and I'll just say that this is kind of each of these areas is something that could probably be a whole hour in itself. So if there's any areas that people have additional questions about, you're welcome to reach out if I don't go into as much detail as you're interested in hearing about. So just to acknowledge some of the sources of funding, for me specifically, I have funding from the Georgia Department of Behavioral Health and Developmental Disabilities, and that relates to work related to prevention of maternal substance use and its impact on the developing child. I won't go into all, this is kind of a busy slide, but there's just to say this is a little bit about our center, the Emory Center for Maternal Substance Abuse and Child Development. And so part of my time is working on prevention, but I also have sort of the other half of my time is at Emory. I'm a clinical psychologist, and so I specialize in working with women that have substance use problems. And so I do about a quarter of my time is in the Emory, it's now called the Emory Addiction Alliance. And so the Emory MSACD, though, has, in addition to prevention work, we do developmental research and brain imaging, and we also have a neurodevelopmental exposure clinic where we do diagnosis and treatment with children, but really 0 to 21 individuals who have been impacted by prenatal substance exposure. So I will start by just talking about the substances that we know are used most often during pregnancy. We'll understand the specific developmental impact of the different substances. So different substances, as you might imagine, have different effects when used during pregnancy. We'll understand how neurodevelopmental disorders are diagnosed related to prenatal substance exposure. So that'll be fairly brief. That it's a complicated process that involves a medical doctor to make that diagnosis. And then the latter half of the talk will review the interventions, as I mentioned before. And so I always like to start by talking about stigma, just because I think with substance use problems, but also for work with children who've been affected by prenatal substance exposure, there's still a lot of stigma. And there are a lot of negative ways that can come up and kind of affect things like access to care for women who have substance use disorders, but also missed diagnosis of children who have prenatal substance exposures. And I'll just say briefly related to this, since it's not such a focus of this current talk, but we know that the majority of the population uses some kind of addictive substance, even if it's only caffeine, and that we do think of substance use problems on a continuum. And so that ranges from no problem at all, maybe people that don't even use substances, all the way to, on the other extreme, people that may have a problem with the substance. And we look to in psychology, the sort of hallmark of having a problem with a substance is that it's causing interference or impairment in one's life. And so that can be things like having withdrawal symptoms if the substance isn't used, using the substance in situations where it may be risky to use the substance, like it could be when caring for children, but it could also be when driving a vehicle or going to work intoxicated. And so when we think about towards the end of the spectrum where people are having a problem with the substance, that's where really we need treatment is needed. But there are many barriers to treatment, stigma being one of them. And especially for mothers who may be using substances, there's a lot of concern and fear of consequences should they disclose their use, either whether that's a risk of having children taken away if they already have children in the home, or their child being taken away once the child is born. And there are also just more generally a lot of barriers to care for women who have substance related problems that I don't necessarily have time to get into today, but there there are logistical barriers, there are access to care barriers, and in addition to those related to stigma. And so I think it's helpful to think about sort of as we're setting the stage, why women might drink alcohol or use drugs during pregnancy. For many, many years, there have been campaigns to increase awareness. There are now legally signs in, I think it's almost anywhere that sells alcohol is required to have a sign up that says that talks about the risks of using alcohol during pregnancy. So there's a number of reasons. The woman may not be aware that they are pregnant. So we know about 50% of pregnancies are unplanned, and especially in the developing child is particularly vulnerable in those early phases of pregnancy. And so it's possible that the person does not know that they're pregnant. They may not be aware of the severity of damage that substances can cause. So I think there's a lot of misinformation out there. My friend drank throughout her pregnancy and her kids turned out just fine. So there's also a lot of information in the media that can be mixed. And so there may just be less knowledge of, maybe it's okay to have just a little bit. We also, again, I kind of mentioned that one. There may be normative substance use in the social group or family where people don't realize that what they're doing might be problematic. They may be using substances to cope with difficult life situations. As we talked about in the previous slide, they may have a substance use disorder, which is considered a medical disease. Again, they may have fears of consequences of disclosing their use. Physicians may not ask, or we know that a big barrier to asking, in not just in physicians, but in anyone that may interact with women who use substances in their children, are that they don't know what resources to point them to should they endorse use, and so they don't ask. And we know that, pregnancy can be an incentive to quit, but it's also potentially added stress, and it's a pretty short time in which to change behavior, social life, and relationships. We know that women who use substances very often have partners that are misusing substances, or they may have the normative patterns within their social group. And so probably for people that are here or watching this, kind of why this is a concern, but we do know that there's inconsistent or inaccurate media coverage. There's with the opioid epidemic, there's a lot of focus on opioids, whereas there's not always as much focus on legal drugs like tobacco and alcohol. And as we'll talk about later, those can have pretty severe consequences. We know that the majority of DFACS referrals in Georgia do involve substance use. So that's another really important, if you have any interaction with DFACS, this is going to come up. It's a larger affected group than we realize. So estimates range from about 0.6 to 32% of those with prenatal exposures will have FASD, and FASD, fetal alcohol spectrum disorders, make up about 10 to 15 cases per thousand. And it's probably even higher in certain high-risk groups, such as those in foster care. So I think it's a larger group of individuals that are affected than we realize. And so just to provide a quick overview of substance use among pregnant women. So the good news is that we know that once that substance use rates reduce significantly during pregnancy compared to when people are not pregnant. So we see about 52% of the population of women report alcohol use when not pregnant, and about 10% report alcohol use when they are pregnant. And an even smaller percentage, about 5%, report binge alcohol use. About 8% each report nicotine or cigarette use and marijuana use. So again, we'll see that it's these legal substances that we often want to be most concerned about. Though of course we'll talk about some of the illicit drugs as well and their impact. And I'm not going to focus a lot on this because we think there are probably some maybe biases is the right word in the data that we have for Georgia, but it's the only data that we have. But we'll see, you know, there are lower rates of alcohol use that we're seeing, at least it has been reported in Georgia, but our guess is that it's probably closer to the national norm. But we do have I think the biggest point with this slide is just to know that we do have some data that's being gathered related to substance use during pregnancy, but we think it's likely an underestimate of actual use. So just to summarize, legal drugs like cigarettes and alcohol are the most commonly used, followed by marijuana and prescription drugs. Cocaine and methamphetamines are next, so stimulants, and then opiates like heroin or prescription pain medications are the used at the smallest amounts, though we do know that prescription pain medications are being increasingly prescribed, and especially among women. But we also know that the majority of women who use alcohol and drugs in pregnancy do use more than one drug. And so really kind of what we call polysubstance use, or use of multiple substances, is more the norm than not. And so I wanted to mention
I had a quick question.
Yeah, sure.
So, and you mentioned this with alcohol, you know, that's something that is legally noticed, et cetera. I'm just curious, because, you know, I don't want to make assumptions, is the fact that the other drugs on your list harmful for pregnancy, is that well known among those who will be pregnant, or like what is the need to do education around those substances as actually being harmful for?
Yeah, so let me make sure I'm understanding. You're saying the other illicit substances that are used in smaller amounts, like what's the
Correct.
need for education around kind of the harm of those?
Yeah.
Yeah, well, I think absolutely there's more information is needed and more education is needed. And I think particularly, well, we'll talk about the specific effects of those substances. I think that particularly with cocaine, I think it's not that one's not really talked about a whole lot. I mean, I think it gets really overshadowed by the opioid epidemic, and I think increasingly attention's being paid to marijuana because of its increased legality across the US. And so I think there are certain substances that more education is definitely needed. And even I think with tobacco, especially, you know, people, I think that's often kind of not really talked about all that much. I mean, I think the good news is people are using it less than they did, 20 years ago, but still a pretty high percentage are using it. And so I think the short answer is definitely more education is needed, and that's kind of what education is really a big role that we have with our clinic, and trying to do talks like this, but in all kinds of settings, talks, but also media and campaigns and ads and things, just to increase awareness.
And
Did
one
that
quick question,
go?
is
Yeah.
there a misconception that vaping is safer during pregnancy?
That's a good question. Trying to think. I think that is true just in general, that many people think that vaping
Right.
is safer. I don't know if we have data specifically on perception of vaping in pregnant women. Let me look at see e-cigarette use. Yeah, I mean there's still lower levels of e-cigarette use compared to tobacco products being used, which suggests that there may um still like higher percentages of people are using tobacco that's more traditionally smoked. But but I think you're right that like more general, like in all groups, there's this perception that vaping is
Mhm.
safer.
Yeah.
And there's definitely misperceptions about um marijuana being safe because it's a plant. And so vaping with marijuana, I think, is another one that's we've seen just higher rates of vaping marijuana specifically, or
Mhm.
THC products, because at least partly because of the perception that it's safe. I think also it's just because it's becoming legal in many places. There's also that perception.
Right, right. Thank you.
Sure. So I know, Marvin, when you and I talked over email, you were anticipating there may be questions that came up about kind of legal issues, and it's not an area that I'm expert in, but I will say I wanted to include this information that I found and kind of gathered through my various sources. So we do know that it's not illegal to use substances during pregnancy. But I think what often happens is that mandatory reporting issues come up at the birth of the baby in a few different circumstances. So if the birth giver's ongoing substance use is judged to put the baby at risk, so for example, if they were using heavily throughout the pregnancy, it is likely without support, they may not just be able to give it up once the baby's born. And so that might contribute to legal reporting issues. If the baby has withdrawal symptoms, that's another instance in which DFACs may need to be involved, or if the baby has negative effects from exposure to the substances. So if they have if they are diagnosed with an FASD. And so ideally, and this is what we very much advocate for, is that support is provided for the substance use problem and to ideally keep the family together. So there are some women only treatment centers that allow that the goal is to keep the family together, so the children either can, live on site with the mom while she's getting treatment, or other sources of support are provided, versus less ideal would be separating the child. But of course, we know that other variables can also contribute to the need for DFACs involvement: homelessness, domestic violence, neglect. So it may not be just substance use. And certain counties in Georgia do have, it may be, another thing is that the way that the laws are kind of implemented may be county specific, like in practice. But there are certain counties that do have pretty supportive programs for women that are judged to be at risk. I know DeKalb, Douglas, and maybe Hall is another one that have supportive programs. Okay, so I want to we started at about 6:40. I want to be respectful of everybody's time and kind of, I'll keep an eye on the time. But I'll shift now into talking about the impact of maternal substance use on the developing child. I know there's a lot of interest in the intervention, so I may go through this a little bit quickly. But again, if any other questions come up about this later on, I'm happy to answer them. So we know that in terms of the kind of teratogenic effects on the developing child, we call it a multi-factor model because it's very complex. So maternal substance use is one potential teratogen, but there are many others. So there's prenatal environment, social factors, legal issues, prenatal care or lack of, factors such as the vulnerability of the organism, related to genetics or other factors. We just have no idea why one child gets affected and another doesn't. There's all kinds of factors that can contribute to developmental issues and teratogenic effects happening for the child. There are various different outcomes that can occur for the child. And all of this interacts, of course, with then the postnatal environment, and can contribute to long-term effects, including developmental, medical, social, and educational. And we'll talk in a lot more detail in the intervention portion about that. And so this slide really summarizes the effects that we've seen in terms of prenatal exposure to substances. I'll go into detail about each of these. When tobacco or nicotine is used during pregnancy, there are a number of both short and long-term negative effects. So those include, in the short term, increased risk of preterm birth, low birth weight, increased risk of infant death, as well as sudden infant death syndrome, SIDS. And then in the long term, we've seen auditory perception difficulties, delays in language development, as well as increased rates of conduct disorders. And so we've already kind of talked about this, that cannabis legality has increased. This is actually from Rolling Stone magazine, but it was the most recent up-to-date map I could find, because this is changing so rapidly. But as you see, I mean, orange are the states where there's no level of legality for cannabis. And so the vast majority of states, and I say this just to emphasize that as a result of this, we really are seeing increased rates of marijuana use across all ages, populations, genders, but that includes in women and pregnant women. And we know that marijuana has this misperception that can't be addictive and that it doesn't cause problems. But the THC concentration levels in marijuana have increased a great deal over the last 25 years. And we know that about 3 in 10 people who use marijuana will go on to develop a cannabis use disorder, so a problem with marijuana. And it's even more likely the earlier that the cannabis uses started. So for teens, the rates are even higher. And I think importantly for this talk, marijuana use in pregnancy is frequently accompanied by other forms of drug use. So a half smoke more than 10 cigarettes a day. About 12% are also using opioids, 10% stimulants like cocaine or methamphetamine. And then about 4% will have an alcohol-related substance use disorder during pregnancy. So as we'll look at the effects of marijuana, we actually don't have a lot of data that shows if you use marijuana, this is going to happen. So we don't have good data that shows, this is a specific negative outcome that's linked to marijuana. So in the short term, we haven't seen any clinically significant effects. So we haven't seen any increased rates of birth defects or effects on growth. Though some have suggested that there is something called fetal cannabis syndrome disorder, similar to fetal alcohol spectrum disorders. It's actually, the vast majority of data suggests that any effects that have been seen are actually effects due to the use of multiple substances. So going back to, it's not so much that it's, at least we haven't seen any consistent results to show marijuana itself alone has these negative effects. It's more that when women are using marijuana, they're more likely to be using other substances. So in these studies, very often women were either using alcohol or stimulants like cocaine or methamphetamine that are likely to explain the effects that are seen. So we don't suggest that women use marijuana, and that's definitely not something we would ever endorse. We go with the National Obstetrics Organizations, who recommend no substance use at all during pregnancy. It's just to say that the state of the data as it is now, we don't have any data to show there are negative effects from marijuana specifically. So moving into alcohol, we know that alcohol, particularly when used heavily during pregnancy, is one of, actually, if not the most harmful substance to the developing child. So it's associated with a large range of negative effects, including increased risk of preterm birth, physical birth defects, growth effects, cognitive deficits, neurodevelopmental impacts, and then fetal alcohol spectrum disorders, what I'll talk in more detail about today. It's the most serious consequence of alcohol use or alcohol exposure in utero, with the most conservative prevalence estimates ranging from 1 to 5%, or about 11 to 50 per 1,000 children. So thinking about kind of in a typical school system, for example, that's a fairly high number, and very often these children get missed. And we do know that FASD is a lifetime disorder. So it includes a range of different types of disabilities, what we call primary disabilities, including intellectual deficiencies, developmental and learning problems, but also medical issues like cardiac problem, vision and hearing loss, motor dysfunctions, and then secondary disabilities, meaning kind of disabilities that result from, even if it's not directly related to the neurodevelopmental impact. So that includes school failure. Mental health diagnoses are typically, we see higher rates of depression and suicidal ideation and attempts. That it can affect vocational success, cause increased risk of legal problems, as well as substance use problems. And we'll talk in more detail again about some of that in a moment, especially when we talk about the diagnosis and interventions. So in terms of opiate use, we see growth reduction, increased risk of stillbirth, and then what many people may know as NAS, or neonatal abstinence syndrome. And I just wanted to mention this across the state. We see the highest number of confirmed cases in Cobb and Chatham counties, but actually the highest rates are seen in more rural counties. So it's hard to see on this map, but those counties are Webster, Jeff Davis, Pulaski, Stevens, and Johnson counties. And this is old data, but it's the most recent that we have for this, that at least has been published. So essentially the main effects that we've seen, in addition to those short-term effects that I just mentioned, are when seen in the infant, when the infant is withdrawing from the substance, if the mother was using them right up until the birth of the child. So those are symptoms that you would see in any person withdrawing from an opioid. Gastrointestinal symptoms like vomiting and diarrhea, central nervous system, agitation, hypertonicity, sleeplessness, there's a high-pitched crying, and increased startle, and respiratory distress. But all of these symptoms, so this is kind of the symptoms of NAS, or it's also called NOWS, neonatal opioid withdrawal syndrome. These all will resolve once the opioid is out of the baby's system. And so typically the standard of care is to ideally keep the infant with the mother and treat those symptoms to help the infant be more comfortable. And then we don't know a whole lot about the long-term effects of opioids. We haven't kind of similar to marijuana, there haven't been any consistent long-term effects that we've seen. So luckily beyond that withdrawal period, we're not really seeing long-term effects. And then finally, I'll talk about the effects of stimulant drugs like cocaine, amphetamine, and methamphetamines. There's increased risk of growth, slowed growth or lower birth weight babies, increased risk of miscarriage and stillbirth, and preterm birth. And we know long-term that there definitely are negative effects of stimulant use in the long term. So the main effect that we see is alterations in what's called arousal regulation, or response to stress. So this is persistent throughout childhood and even into adolescence. And basically this would be a baby that has a heightened response to stress, that may perceive situations as more stressful as compared to other babies, and has more difficulty soothing or calming themselves. Any questions about anything I've gone over so far before I get into FASD specifically? I know it's a lot of information. There's a lot to go into, but okay, so I'm now going to shift into talking about FASD specifically, because as I mentioned, this is the area that really has the most research in terms of the most consistent effects that have been seen, and also the most research in terms of interventions. And so just to briefly talk about how FASD is diagnosed, so we, of course, assess for a history of prenatal exposure. So that's typically important information, but what's challenging is there are some settings where we may not have that information. So for example, if a child has been adopted or has been in the foster care system, we may or may not have that information. There's a certain pattern of facial features, growth, and in the brain that we look for. I won't go into all of the details here, but this is done by a trained physician in looking for certain patterns in facial features that are typical of children that had prenatal alcohol exposure. There are certain cutoffs for weight or length of the baby that we also look for that are most evident in the neonatal period, and head circumference is less reliable and so not typically used. There are some cutoffs that use a 3rd percentile cutoff, and others use a 10th percentile. And then we also, in terms of the patterns we see in the brain, we see reduction in overall brain volume, malformations and reductions of volume of gray and white matter, thin or missing corpus callosum, and alteration in certain brain activation, as well as connectivity among different parts of the brain. And this is just to show that there really is a pretty large burden of care for individuals with FASD, that different services that they'll need throughout their lifetime. So that is in physical health and motor areas, developmental and cognitive areas, behavioral and social, as well as academic and vocational. And I will say, when we think about FASD, it's really important to focus on the individual. And so there are many individuals that may not need all of these services, but then there are some individuals who will need services in all of these areas. So while it's important to look at the individual, this kind of gives a picture of all the different areas that may be affected, and that in terms of resources and time for the family, it's a lot for families there's a lot of different areas of support that are needed. So there are a few different areas that we think are affected most for individuals with FASD. So this includes impairments in intellectual ability. So there are delays in development and cognitive deficits that we see. There are academic deficits like learning disorders and academic underperformance. And then we also see certain behavioral deficits, attention problems, some externalizing behavior problems like impulsivity or aggression at times. Sometimes there are also self-injurious behaviors. And we think that there's one sort of common factor that explains all of these difficulties, which is an impairment in what's called arousal or regulation of arousal. So we talked a little bit about this idea with the effective stimulants in terms of difficulty, greater stress reactivity. In infants, we might see this as impaired just more negative emotions and difficulty with soothing or being soothed, sleep disruption. And then as we move into early childhood in the school years, we might see kind of a range of mood changes, irritability. We might see some behavioral outbursts, difficulty encoding new information, difficulty shifting attention from one task to another, sustaining mental effort on one particular task, and impairments in inhibition or impulse control. So that's a very brief overview, but I wanted to make sure to make time for interventions. And so that I think it can feel a little bit overwhelming to think about all the different negative impacts, but the good news is that we do have a number of interventions that have been shown to be effective in working with kids and families. And so there's a few different domains that I'll talk about. One is the area of safety. We'll also talk about social skills, academic skills, as well as those that focus on self-regulation skills. So the first area that I'll talk about is safety. So we know that it's important, and because of some of the difficulties I described a moment ago, there may be deficits in certain types of social skills and in awareness of safety in particular. So that can include things like stranger awareness, good touch, bad touch, fire safety. As moving into the teen years, phone safety is really important. So if we think about the problems with impulsivity and inhibition, these are some areas that are really important to focus on with these kids and teens. And so I've included a few different resources here that are sometimes used. There's these kind of virtual reality programs and games that kids can practice to learn some of these skills. And this Moment to Moment is a documentary about teens growing up with FASDs. So there's some different resources that can help teens and younger children learn these safety skills. And then there are also a number of social skills interventions that can be helpful. And so individuals with FASD may be actually overly social or potentially socially disinhibited. So some of what we see socially is kind of on the opposite end of what may be seen with somebody on the autism spectrum, for instance. So there may be actually a real desire to connect socially, but a difficult time reading social cues. We'll talk in a moment about increased visual spatial difficulties, and that can lead to difficulty reading social cues. And so there are a couple of different programs, often that involve parents or peers to help facilitate the learning of social skills, things like learning about nonverbal communication, conversation skills. how to join a group, impulse control, things like sportsmanship and teamwork, depending on the age, how to deal with teasing, assertiveness skills, and anger management skills. And then moving into the academic skills that are important, this is an area where probably the most, in general, there's not a whole lot of research on interventions for FASD, but the most data that we have focuses on academic skills. And so one of the most evidence, programs that has the most evidence is called MILE. And so this is, we see in individuals with FASD that there are greater deficits in math as compared to spelling and reading. And there are some patterns in the difficulties with math that are seen that are really targeted with this intervention. So it includes visual spatial confusion, some difficulties with fine motor problems, which affect handwriting, problems understanding time and direction, difficulty learning to count, trouble with reading, writing, and copying numbers, and difficulty understanding certain symbols as well as a typical number line. So this is just an example of MILE uses actually a vertical number line as opposed to what's often used in educational settings is a horizontal line. And this is really to help with the visual spatial difficulties that individuals with FASD have. So we don't think it's the math difficulties that are seen are really thought to be a product of more of an underlying core deficit that relates to motor skills, that arousal regulation that I mentioned earlier, the visual spatial skills, as well as with learning. And so MILE really helps teach methods to address these underlying problems. And again, could be like a whole workshop in itself, but just to provide an overview, there's a parent education component, there's MILE, the one-on-one instruction with the children that focuses on learning skills in those different areas. And so it really focuses on a slow building of a solid foundation of basic math skills. So for example, a child needs to be able to recognize the size and shape of an object before skills like sorting and categorization can be learned. And so we really want to think about, for that child, where are they developmentally? They may not be at the same level kind of as age expected. And so we want to make sure that they have these core skills before moving on. Then there's training for instructors, and then a train the trainer curriculum. And this is just a example of the improvements in handwriting that we have seen, but we've seen, or handwriting and writing numbers, but also in handwriting. We saw, but more generally, that the parent education component had positive gains on the neurodevelopmental deficits, particularly for arousal regulation, behavior, and learning. And we also saw positive impacts in behavior management and social learning principles. We really found that scaffolding was really important to the children's learning needs, as well as integration of strategies with the school and the family. And so what seems to be most important is an appropriate environment, a simplified learning environment, reducing chances of failure or making the wrong choice, which can lead to frustration, which can then interfere with learning, as well as teaching in what we call a calm alert state as sort of the ideal arousal state. And then the final set of area of focus is on those self-regulation skills related to the arousal regulation difficulties. And so there is a number of different programs related to that have behavioral regulation training, but one that our group has been a part of is called Go Far. And so this focuses on what we call metacognitive skills. So learning to learn, basically. And the different components of this intervention relate to giving some education to the parents, typically parents or other caregivers, about FASD. There are 5 parent behavior regulation training sessions, and then 5 child sessions that use this computer game, which is this is a screenshot from the computer game. And then there are 5 didactic trainings with the parent and child for implementing FAR in the context of adaptive living skills. So I'll give an example of that in just a moment. But behavioral regulation training incorporates behavioral management training principles, really is focused on things like social learning principles, helping the parent to modify the child's level of arousal, develop a toolbox of arousal reducing or regulation skills and strategies, helping the parent or caregiver to anticipate any problems or when their child might be getting on this curve from excited alert to upset and crying, and trying to intervene earlier and maybe give the child a break or bring the child away from the situation to help them use some skills to reduce arousal, because we know once they're in that latter part of the curve, it's going to be pretty hard for them to use skills and stay engaged. And so this is just an example of a plan using this metacognitive strategy applied to the adaptive skill of breakfast in the morning. So the therapist and the parent and child are all going through this, where you're identifying what is the activity, you're helping them think about ahead of time, what do I need to get, in this case, breakfast ready, what do we need to use, what needs to be done first and next and after that, so what is our plan? And then we're having them practice it and talk through what they're doing, reflect afterwards. What did we do? What was our plan? Did we follow that plan? So it's really thinking about thinking, and that's really the skill that we're teaching and then as it applies to these adaptive skills, but it can also be applied to other areas as well. And then the final piece is planning for generalization. So what can we do? How do we apply this in the future? So this FAR technique, whether it's learned through a computer game or through behavior BAT sessions, we saw improvements in behavior. And we're able to see, I think this is really important, because before these studies were done, people weren't sure whether children who were affected by prenatal alcohol exposure whether interventions were going to be helpful. And so I think this is really important to know that there are interventions that are effective. We know that parent involvement, or I should say caregiver involvement, is very important. It's a really important component. And for parents or caregivers, advocacy is often a really important role. And so in summary, what can we do to intervene with children affected by maternal substance use? We need to be asking about maternal substance use during pregnancy and during child rearing. We need to be screening infants and children for effects of prenatal exposure and increasing our just awareness of these children so that they can get the services that they need and that will support them to be successful. Referring children for further evaluation, supporting caregivers in getting them evaluated and obtaining needed services, being aware of available resources. And I'm happy to share, we have lots of resource lists that I'd be happy to share. And then working effectively with school, the whole system that individuals with FASD and their families interact with: schools, Babies Can't Wait, mental health providers. Going back to that burden of care, there's often a lot of people involved to help support these individuals. So I know there's only a few of us here, but I'm happy to answer any questions that anyone may have, or certainly, again, people can reach out to me if they're viewing this recording. we always welcome feedback on presentations, and if there's more that people would like to hear about or any other feedback, we're always welcome that. Any questions from anyone here?
I have a, think I quick question.
Mhm.
So, this training is for providers, and again, I'll send this to particularly the parent centers that had expressed interest.
Yeah.
Um, is there what is the best screening tool to use or to implement for providers that are interacting, whether in the school setting, in the home setting, other settings, in order to determine whether someone who's pregnant is at risk? Yeah, I guess I'll ask that because I know that there are screenings covered by preventive care for a variety of different behavioral health type things, but I was wondering if there was like a best practice type screening, particularly one that perhaps had been validated and across cultures and even languages
Yeah.
for
Yeah.
this.
Um, that is a great question. I'm trying to think of, I mean, one of because going back to the idea that the diagnosis is fairly complicated and done by a medical professional. I mean, sometimes the best thing is more related to questions about whether substances were used or are being used during pregnancy, so that then referrals can be made for diagnostic evaluation. I think I'm trying to think of if any screening, are you thinking about screening tools for FASD specifically, or more for, is that what you were thinking about?
I,
Or
it was a universal question, certainly for FASD, but also for any of any of the substances we've discussed that would
yeah,
put
yeah,
mom and baby at risk.
yeah. So I think like what I would probably say is I think the best practice sort of relates more to whether substances were used during pregnancy, um, if the person is pregnant, or if it's kind of retrospective, or reporting back on whether substances were used, and then knowing the resources to refer people for evaluation, because it's because the diagnosis is so complicated. I think that's probably the best practice.
Gotcha.
Yeah.
And then my second question, and then
Mhm.
I'm done,
Mhm.
is speaking of where you, and I think I'll speak for all of us. We would love any resource list that you have.
Yeah.
But speaking more immediately of what you just mentioned, and you mentioning that the diet, because I will say, like, I knew some of this, but this is overwhelming. It the diagnosis is complicated. Where would we refer someone that, for example, we know that someone did use substances regularly during pregnancy? Would that just generally be to a PCP? I mean, just because you mentioned that the diagnosis can be complicated, what is
Yeah.
the
So
thing to do?
our Emory, actually, we have the Emory Neurodevelopmental Exposures Clinic, is a diagnostic clinic. There aren't very many of them, particularly in the Southeast, but I would say in the country in general. But Emory has that clinic, and so that's often that's a resource that we give out widely, and I can send you that as part of our resource list. But so that would be kind of getting there's a suspected exposure, figuring out, like, is there a developmental impact, is there a diagnosis, and then is there what are the cognitive and developmental impacts of that exposure. I believe our clinic is the only one like that in the state of Georgia, and it might even be in a pretty wide area in the Southeast. But there are certainly other resources that I can send you for other kind of support, if not just related to diagnostic
Yeah,
assessment, but just kind of the different areas of support that these
that would be
families
great.
might need.
Quick sub question. I think it's quick.
Sure.
Does the center, the research you just meant, does that require a physician referral, or what kind of referral does that require, if
No,
any?
anybody can actually call up our
Oh,
clinic.
wow.
Yeah,
Okay,
yeah, it
okay,
does not require a physician referral.
cool.
Yeah,
Thank
so
you.
that information will be in the resources that I
Awesome.
send. Yeah,
Yeah, that's awesome. Thank you.
sure.
One thing some of you, a lot of your resources I noticed had parents work or caregivers, as you said, working with these children. I imagine that there's a great deal of emotion from caregivers if a child is diagnosed with something. How do you get them from that diagnosis to working with the kids to, I imagine that that's a very long and somewhat rocky, or
Mm.
could be a very rocky trip.
Yeah, absolutely. And I mean, there's a whole uh, well, there's a whole research area related to the need for caregiver support.
Mm,
But clinically, absolutely, that is such an important piece of what we do is whether that's support group. I mean, support groups are one form that can take, but also
mhm,
just making sure that the parents or caregivers feel informed, supported, have the validating the whole process. I think absolutely, as you said, it can be overwhelming.
mm,
And very often we work with adoptive or foster parents too. So there's a whole added stress
yeah.
potentially that's associated with that. And so that is a really important point that you're pointing out, is that just the care, that burden of care and the caregiver stress can be really high, and we want to really provide a lot of support for that.
Okay. Okay. Great. Thank you.
Sure. I know I don't know if there's like one particular trajectory, but absolutely
Yeah, I'm sure
acknowledging.
there's many. Yeah.
Yeah, but absolutely acknowledging how overwhelming it can be and providing as much support as possible, and helping connect to other parents who may have gone through similar
Mhm,
things.
mhm.
Yeah.
That's incredible. Okay.
Um, all right. Well, why don't Marvin, what would be the best way to